Our next speaker is a consultant endocrinologist at Narayana Institute of Medical Superspecialty, Nanded. He has received A.D. Gandhi Award 2017 for excellence in endocrinology. Also, he has to his credit 22 publications in index journals. Please welcome Dr. CHAITNYA YERAWAR. The topic is interpretation and management of calcium disorders. The chairpersons for this topic are Apollo's senior neurophysician, Dr. Monica Malukar, and senior physician, Dr. Shirish Dehantan.
At outset, I want to thank organizers for giving this opportunity. I will be discussing about interpretation and management of calcium disorders. This will be the outline of the talk. We will see how the calcium homeostasis
how it implicates in our routine practice, the case-based approach to hypo and hypercalcemia and its management. So 99% of the calcium is sequestrated in the bone and just 1% is in the circulation. Out of this 1%, 10% is bound to phosphates, 40% is bound to albumin, and just 50% is which is active ionic calcium. So when we estimate total calcium, it is combination of both bound and free form. So this is 4-year boy being treated for nephrotic syndrome, a low calcium, and this is quite surprising, calcium of 7.1 and patient is asymptomatic. As this patient is nephrotic syndrome, we estimated albumin level which came low. So we evaluated albumin corrected calcium and this came 8.7. So whenever you estimate total calcium, it should be corrected for the albumin, at least in the patients when the clinical condition doesn't match with the calcium level. Normal calcium, if patient is symptomatic, you have to estimate albumin corrected calcium level. The binding of this calcium to the albumin is pH dependent. In acidosis, there is a decreased binding, so the free ionic calcium will be increased, while in alkalosis, this binding increases, so the ionic calcium level will be decreased. 27-year female came to casualty with taphoidal spasm. She was anxious, in panic attack and hyperventilating. Her calcium is normal, but her ABG suggests of respiratory alkalosis. As I said, in alkalosis, the binding of the calcium to the albumin will be increased, so the total albumin level will be normal, but the functional ionic calcium level will be low. So in her case, ionic calcium was very low. So we have to estimate ionic calcium whenever you suspect an acid-base disorder. The calcium homeostasis involves 3 major organs like bone, gastrointestinal tract, and kidney, with the help of 3 common hormones: PTH, calcitriol, and calcitonin. So whenever there is a decrease in calcium level in the serum, it is sensed by the CASR receptor on the parathyroid gland. It produces more PTH. This PTH acts on the PTH receptors in the bone, causes bone resorption, so calcium will be released in the circulation. It acts on the kidney, it increases calcium absorption and it increases phosphorus excretion. Simultaneously, it increases 1-alpha hydroxylation, so more calcitriol will be available. It will increase the calcium through the gut and it will normalize the calcium level. So whenever we want to evaluate a patient with calcium disorder, we have to order a calcium profile which consists of calcium, phosphorus. When we order phosphorus, it has to be done in the fasting state, as after eating, because of release of insulin, it may get sequestrated inside the cells. So we have to collect phosphorus in the fasting state. Again, we have to tell our staff not to apply tourniquet, as majority of the phosphorus is intracellular. Application of tourniquet or squeezing the arm can cause false elevation of phosphorus level. Other components are like alkaline phosphatase, creatinine, albumin, PTH, and 25-hydroxyvitamin D, 125-hydroxyvitamin D, and magnesium. To mention about PTH, PTH is unstable at room temperature. So whenever you are collecting sample for the PTH, you have to inform lab you are collecting the sample, set the sample on the ice, and you have to analyze immediately. So when we want to interpret PTH, it should not be done standalone. It has to be interpreted along with calcium level. This curve is more or less related to T4 and TSH level. Any small decrease in a calcium causes significant increase in PTH level. So let us understand how to interpret low calcium, low PTH. we are dealing with hypoparathyroidism. Low calcium, normal PTH. Still we are dealing with hypoparathyroidism because even a small degree of decrease in calcium should raise the PTH level. So this is inappropriately normal. So this could be a case of hypoparathyroidism. Low calcium, high PTH. This is usually seen in patients with secondary hyperparathyroidism, in patients with vitamin D deficiency or CKD patient, or this could be a case of pseudo hypoparathyroidism. High calcium, high PTH, hyperparathyroidism. High calcium, still a normal PTH. Again, body should not produce PTH when the calcium is on a higher side. So some say cutoff of 20. High calcium, PTH more than 20, still it can be a hyperparathyroidism. High calcium, low PTH. It is a PTH independent hypercalcemia, maybe because of PTH RP or because of excess production of 125-dihydroxyvitamin D. Our endocrine colleague can agree, even with the normal calcium and high PTH, we can still have a normal calcemic pH. So coming to approach to hypocalcemia, patients with low calcium level confirm with either ionic calcium or estimate albumin corrected calcium. If the hypocalcemia is confirmed, measure phosphorus. If it is normal or low, estimate 25-hydroxyvitamin D. If it is low, then we are dealing with vitamin D deficiency. If 25-hydroxyvitamin D is normal, estimate active vitamin D. If active vitamin D is low, then we are dealing with vitamin D dependent rickets type 1. And the active vitamin is high, then we are dealing with viridia-2. If the phosphorus is high, then measure creatinine. If creatinine is high, we are dealing with a case of chronic kidney disease. If the creatinine is normal, then measure PTH. If PTH is high, then we are dealing with pseudo hypoparathyroidism. If PTH is low, again estimate magnesium level. If it is low, it is hypomagnesemia. And if it is normal, then we are dealing with primary hypoparathyroidism. Let it be genetic or surgical. So 4-year-old boy presented with knock-knees. Calcium profile suggestive of low calcium and low phosphorus. Phosphorus may be normal for adult, but for the pediatric age, this is definitely low. So if we see the algorithm, hypocalcemia, low phosphorus, so we should estimate vitamin D. Vitamin D came very low. So this is the case of vitamin D deficiency rickets. We usually give 60,000 international unit of vitamin D weekly for 6 to 8 weeks, followed by required daily amount. 3-year girl presented with bowing of legs, calcium profile suggestive of low calcium, low phosphorus, and low 25-hydroxyvitamin D. PTH is low. What is unusual in this case is, as I said, in vitamin D deficiency, we expect PTH on a higher side, but in this case, PTH was on lower side. So again, we re-estimated PTH. PTH came as normal. So when we asked about previous sample, the sample was collected 1 day prior. It was kept at a room temperature. That's why the readings were low. So we have to collect the previous sample and analyze as early as possible. 4-year-old boy presented with knock-knee and episodes of generalized tonic-clonic convulsions, low calcium, low phosphorus, but this time 25-hydroxyvitamin D is normal. So by algorithm, we estimated 125-dihydroxyvitamin D, which came low. So this is the case of VDTR1. So this is about vitamin D synthesis. In VDTR1, there is a defect in 1-alpha hydroxylation. There is an adequate 25-hydroxyvitamin D is in the body, but because of renal defect, it is not converted into active vitamin D. We usually give active vitamin D in a physiological dosage 0.5 to 1 microgram per day. 8-year-old boy presented with multiple bony deformity. You can see the bowing of legs, multiple recurrent fractures. Calcium profile suggestive of low calcium, low phosphorus with normal vitamin D. In this case, active vitamin D was very high. So this is a case of VDDR2. So what happened in VDDR2? There is a defect in vitamin D receptor. There is a formation of active vitamin D, but it is not able to act. So in this case, these cases are really challenging for the management. We have to give very high doses of active vitamin D. Sometimes they may require IV calcium also. A 14-year girl presented with short stature and tachypneic spasm, low calcium and high phosphorus, normal vitamin D, and PTH came as 108. So the treating consultant labeled it as a pseudo-hypoparathyroidism, low calcium, high PTH. If we see the algorithm, if the calcium is low and the phosphorus is high, first thing to estimate is the creatinine level. So when we review, creatinine was high. So basically this is a case of chronic kidney disease which is labeled as a pseudo-hypoparathyroidism. So estimate creatinine first before labeling it as a pseudo-hypoparathyroidism. 9-year girl presented with short stature and recurrent episodes of convulsions. She is having low calcium, high phosphorus, normal creatinine, and in her case PTH was low. So this is a case of pseudo-hypoparathyroidism. Again, magnesium was normal. If we see her face, she is having syndromic features in the form of thinning of upper lip, pinched nose, long philtrum, and the skeletal survey suggestive of narrow medulla and increased cortex. We did a clinical exome sequencing, and this sheet turned out to be a Kenny-Caffey syndrome. So basically, we published this case last year in Oxford Journal of Medicine. Coming to approach to hypercalcemia, a patient with high calcium confirmed with either ionic calcium or estimate albumin-corrected calcium. If we confirm this, ask about medication history. The common drug which causing hypercalcemia like vitamin B toxicity, vitamin A toxicity, patients on diuretics. If there is no history of medication, estimate PTH level. If it is high or normal, measure 24-hour urinary calcium creatinine ratio. And if it is low, then we are dealing with familial hypocalciuric hypercalcemia. And if it is high, then we are dealing with hyperparathyroidism. If the PTH is low, then in this case we have to measure PTH-RP. Hypercalcemia with low PTH, that is PTH independent. If PTH-RP is high, then we are dealing with humoral hypercalcemia of the malignancy. And if the PTH-RP is normal, we have to estimate active vitamin D. If the active vitamin D is high, then we are dealing with chronic granulomatous disease like sarcoidosis or tuberculosis. And if it is low, the other endocrine disorders like adrenal insufficiency, acromegaly can be a cause of hypercalcemia. 59-year female, known case of diabetes and hypertension. On routine evaluation, she was found to have hypercalcemia with normal phosphorus level. On medication history, as she is postmenopausal, she has received tons of vitamin D. In fact, she has received 6 injections of paracetamol weekly for 6 weeks, and her 25 vitamin D level was very high. So this is a case of vitamin D toxicity leading to hypercalcemia. 25-year male presented with backache, decrease in the height because of vertebral compression, recurrent renal calculus. Calcium profile suggestive of high calcium and low phosphorus level. If we see the algorithm, the next thing is PTH. PTH was very high. To know the source of the PTH, we did a 4D CT. 4D CT is just a routine CT. Only thing, after contrast, we take images at a different time, 0, 30, 60 and 90 seconds. And this patient was having left inferior parathyroid adenoma, and there is a resorption of terminal phalanges, nostolytic lesions. This case we recently published in Annals of Clinical Radiology. 34-year male, generalized weakness, weight loss and cervical lymphadenopathy on clinical examination. Hypercalcemia, low normal phosphorus with low PTH. As the PTH-RP was not available at that time, so we went ahead with the estimation of active vitamin D, which came very high. The lymph node biopsy we did turn out to be a tuberculosis. So this is a case of chronic granulomatous disease, that is tuberculosis leading to hypercalcemia. So how this tuberculosis causes hypercalcemia? In tuberculosis, there is activation of T lymphocytes and macrophages, which produces more 1-alpha hydroxylase, which leads to more active vitamin D and more calcium. This does not happen in every case. Patients, elderly patients, dehydrated patient, when there is a spillover of the active vitamin D, you will get hypercalcemia. So coming to management of hypocalcemia, if the patient is asymptomatic or if the calcium is mildly deranged, Most of the time we will manage on the oral supplements. Two common agents we use are like calcium carbonate and calcium citrate. Calcium carbonate contains 41% of the active calcium by the weight. So when we give a 1250 milligram of the calcium, it gives 500 milligram of vitamin calcium. The only thing is calcium carbonate requires acid for its absorption, so it has to be given with the meal. While calcium citrate contains 21% of the elemental calcium by the weight, it does not require acid, so it can be given without regards to the meal. It can be given in patients with achlorhydria or patients on antacids. These are the other common formulations we give in our OPD. If the patient is having severe hypocalcemia, we give a bolus of calcium gluconate. 1 to 2 ampules of calcium gluconate dissolved in 50 to 100 ml of NS given over 10 to 15 minutes, and this should be followed by an infusion. We make this with 5 ampule of calcium gluconate in 500 ml of NS, give around 1 to 2 ml per kg. In patients with post-surgery hypoparathyroidism, we usually add calcitriol in the dose of 0.25 to 0.5 and monitor calcium level weekly, then monthly, and then every 6 monthly. Coming to management of hypercalcemia, mild hypercalcemia, we have to find the medication and if possible stop that drug, and oral hydration will take care. In case of severe hypercalcemia, we have to do aggressive hydration and sometimes we have to use bisphosphonate also. So hydration basically causes calciosis. We give around 100 to 200 ml of NS per hour. And after adequate hydration, we give diuretics, loop diuretics, furosemide 40 to 80 mg IV 12 hourly. The second line agents are like calcitonin. We give 4 to 8 units subcutaneously. The only thing with calcitonin is it will act for 2 to 3 days. After that, patient will have tachyphylaxis. Bisphosphonates, again, if the patient doesn't respond to hydration and after calcitonin, we can give bisphosphonate 4 mg dissolved in 100 ml NS given over 10 to 15 minutes. And again, we can use steroids, particularly in those patients with chronic granulomatous disease or in lymphoma. They decreases 1-alpha hydroxylation. Hydrocortisone can be given in an initial part. After that, they can be controlled with the prednisolone. So just to summarize, total calcium should be interpreted along with albumin level. Whenever you are dealing with a patient in which there is acid-base disorder, estimate ionic calcium level. Phosphorus should be collected in the fasting state. Don't apply tourniquet or squeeze the arm. Estimate PTH as early as possible and it is unstable at room temperature. Mild hypocalcemia, managed with oral calcium. Severe hypocalcemia, require calcium gluconate bolus followed by IV infusion drip. Mild hypercalcemia, stopping of the drugs and oral hydration will be sufficient. While in severe hypercalcemia, you may have to give aggressive hydration. This is our Narayana team. Thank you.
Sorry, thank you, Dr. Chaitanya. Now I would like to invite questions from the audience.
So, what will be the symptoms of hypercalcemia? Severe hypercalcemia?
Severe hypercalcemia present with irritation. They may have whatever you can say constipation, ST changes. They are very irritable.
So, post-thyroidectomy status.
Yes.
It is mostly presented with hypocalcemia. What to do? Either correct anemia, hypoproteinemia also, or some other measures.
So post-hypoparathyroid patient, post-surgery, we usually give IV calcium if the patient is symptomatic. It can be transient if it lasts for less than 6 months. And if it is lasting more than 6 months, that could be a permanent hypoparathyroidism. Most of the time, IV calcium and after settling the calcium, the patient can be managed with vitamin calcium and active vitamin D.
I think because we are running short of time, we restrict our question and answers here. It can be discussed later on with the faculties one-on-one, and we proceed with the. Sorry to interrupt.
Thank you, Dr. Chaitanya.
And to save the time, I think we are not having a tea break also. Tea will be served at the place here inside the hall so that we can finish the sessions on time. Thank you.
Thank you, sir. I request the faculty and chairpersons to please proceed towards the center of the stage.
Dr. Ankush to felicitate the chairperson.